Hi, this is Brian Kim. I'd like to share with you this case of a dislocated IOL that was referred to me. When I took this patient back, I realized that there was no visible IOL. So I went ahead and proceeded anyways. I placed my trocar 3.5 millimeters posterior to the limbus. I made my stab incisions. And when I put the trocar in, I did notice something wobbling in the vitreous space. So I was hopeful that maybe it was still there. Because the pupil is small, I went ahead and placed iris hooks. This is pretty typical. This patient probably had pseudoexfoliation, and these pupils don't dilate very well. This patient did receive dilating drops, but did not dilate very well. So I'm placing the hooks one at a time, using the stopper to kind of rotate the hook downward and then engaging the iris. And then I make the more stab incisions, place some dispersive viscoelastic to coat the corneal endothelium. I make my triplanar corneal incision, make the vertical groove and tunnel, and then enter into the anterior chamber. I place a viscoelastic cannula in the trocar opening, and I noticed that thankfully the lens was still attached by a hinge. I was very lucky here. I went ahead and used some 23 gauge micro forceps to try to prolapse the bag and IOL complex into the anterior chamber, but if the pupil's too big, it's going to just go right back down. So I had to take those hooks out on this side, prolapse the lens bag complex upward. It's a little bit tricky because the bag is soft and mushy, and it's really hard to grasp the parts that you need, such as this haptic that I was able to grab, because the bag is mushy, and trying to grab the optic is difficult because it's cocooned in this mushy bag, and there's a Summerings ring there. And so, but ultimately I was able to get most of the lens upward. I took the remainder of these hooks out, and I used this Maltzman to prolapse the lens upward above the iris plane. And then I used these micro instruments to bisect the lens in half and then remove each piece. Now there's this large Summerings ring left, and I'm using viscoelastic to tease the Summerings ring anteriorly and then try to burp this material out of the wound without having to make the incision larger. It's a little bit of a challenge to do that step. I place my 23 gauge Lewicki AC maintainer and then perform a vitrectomy. Fill the anterior chamber and coat the cornea with viscoelastic. I make my marks, again 2.5 millimeters posterior and then 2 millimeters adjacent. Make my contralateral incision for the trailing haptic first technique. This is the right needle. I'm bending that about 3/4 from the tip. The left side is bent at the hub. I'm using, with the help of my assistant, injecting the CT Lucia 602 lens into the anterior chamber. I'm retrieving the leading haptic and pulling it out to the limbal incision. And then I'm making the U-shaped configuration to my trailing haptic. I go ahead and tunnel through the sclera on the right side, tunneling 2 millimeters, and then using my micro forceps to grasp the curve of the U of the haptic and tunneling the haptic through the needle, disengage the syringe from the needle, and then pull the leading haptic into the anterior chamber with the micro forceps. Perform the same procedure on the left side, tunneling 2 millimeters and then diving in. And again, I'm taking advantage of the bevel. The bevel in each case is facing, the right one was facing towards me, the left one was facing away from me, and that is so that the bevel will accept the angle of approach of the haptic, which has that C-shaped configuration. And then you go ahead and continue to tunnel the haptic through the needle. As I pull the needle out, I have McPherson forceps to ensure that not too much of the haptic is externalized. And then I cauterize the tip, and I perform the exact same procedure on the other side, pulling the needle out, but ensuring with the McPhersons that I'm not pulling out too much haptic, and then cauterizing the tip. And then I push the haptics flush to the sclera and cover the haptics with conjunctiva, reapproximate the tissue. You can see the lens is very well approximated here and in good position. Go ahead and place the tenon suture through the main incision because you don't want any potential vitreous to prolapse anteriorly. And then hydrate my incisions. I pull my trocar out and massage my sclerotomy, which should be self-sealing. And then I pull the AC maintainer out, hydrate the wounds, and this is the end of the case. So I was very fortunate that this lens bag complex was hanging by a few zonules. I was able to save the patient from needing retinal surgery. The learning point for this was when the lens is dislocated like this, obviously the pupil was small from the beginning. I put the iris hooks in. Once the lens is elevated up at around the iris plane, you need to remove the iris hooks in order to be able to capture the IOL bag complex within the anterior chamber. So that's the most important part. If you don't do that, then you're going to continue to struggle and you'll risk the lens dislocating back into the vitreous space, especially once you start manipulating it. Those few zonules that it was tethered by will be completely gone. So this is my levitation of the dislocated IOL case with Yamane. I hope this was helpful to you, and thank you for your attention.